Greetings and welcome to this month's Royal Brompton and Harefield Hospital's virtual Grand Rounds. We are pleased to present a webinar on AI in cardiology, a webinar that has been created with the use of artificial intelligence.
Good evening, everybody. Welcome. I hope you can see me. My name's Richard Grocott-Mason. I'm a cardiologist and the chief executive of Royal Brompton and Harefield Hospitals and the Heart Lung Critical Care team of Guy's and St Thomas's. So this is a first for me, having to chair a session with an avatar and Professor Lucia. I think it's going to be fun and informative, I hope, and generate lots of questions. And I think this is clearly an insight into our future worlds, which some may think are really exciting, others of you might find really quite scary. But I'm going to hand over to Professor Lucia. We're then going to have the talks and the slides, and then we'll have some questions. I don't know whether any of the audience are avatars and going to ask questions as well, but let's see. Anything could happen. So, Tom, over to you to start the session, please.
Thank you very much, Richard. It's a pleasure to do these Royal Brompton Grand Rounds. And I think artificial intelligence and machine learning is knocking at the door of our clinical practice, in particular in cardiovascular medicine. That's a very visual and auditory discipline of medicine. And therefore, we have lots of data. The data revolution provides us with genetics, with biomarkers, with ECGs, with clinical findings, with imaging. And of course, the stressed human brain has a hard time to put everything together into a picture that will allow us to provide optimal care to our patients. Now, artificial intelligence really is working like this, that it starts with lots of data, be it genes, clinical findings, biomarker, the ECG, laboratory test, histology, X-rays, you name it. And this will go into a computer that is a network like our brain. And then, of course, will provide unseen data that are into an algorithm that is informative for our clinical practice. And then, of course, we have to validate it. Now, as it works like a neural network, my favorite philosopher in this context is Ludwig Wittgenstein, a very difficult person that, but however, made a career in Oxford because the English are much more tolerant to special personalities that are geniuses. That's why he wasn't in Austria, but rather in Oxford and Cambridge, a professor. Then on the other hand, we have Plato that said we have to understand the idea of a disease, but that's not how artificial intelligence works. The Wittgenstein's language games that he published in the Philosophical Investigations in the 50s after his death, he said that as a child, we learn what is a chair because we learn about features of a family. Resemblances. A chair can have four legs. It can turn around. It can have one leg if you're a farmer. It can have three legs, or Coloni's chair doesn't even have a leg. So that's how we learn. And the computer is very much like our brain. So how can we apply this to medicine, in particular to cardiology? Well, we can have genetics. We can have auscultatory findings, clinical findings, biomarkers, an ECG, and this all together produces a feature that in some patients have more weight on clinical, more weight on the ECG, or more weight on the beta, on the biomarker, but eventually we'll put this into a large database, basically a computer. And the data entry and training and derivation cohort will then be produced through an algorithm that for most physicians is a black box. For mathematicians, it is a clear structure. And then, of course, we will provide a first algorithm that we might be able to use. But this is not good enough because algorithms like tests have to travel well from one city to the other, from one hospital to another, and maybe also from the UK to the continent, as we say here. And then, of course, we will have a validation cohort. For instance, we are using UK Biobank data and then use Sweetheart in Sweden to verify it. And then we go back to the computer, and eventually we have a confirmed algorithm. So basically, we can say that an algorithm has to transit geographical and other
Artificial
borders.
intelligence and machine learning can significantly aid cardiologists in various aspects of patient care and research, enhancing diagnostic accuracy, treatment efficacy, and overall patient outcomes. Here's how AI and ML can be particularly beneficial in cardiology. AI algorithms can analyze complex diagnostic data, such as ECGs, echocardiograms, cardiac MRIs, and CT scans, with high precision, often identifying subtle patterns that may not be apparent to the human eye. This can lead to early and more accurate diagnoses of conditions like myocardial infarction, atrial fibrillation, and heart failure. AI models can integrate diverse data sets, including clinical, genetic, and imaging data, to stratify patients by risk more accurately and predict outcomes. This can inform personalized treatment plans and identify patients who may benefit from more aggressive interventions or monitoring. AI can help in tailoring treatments to the individual characteristics of a patient, considering their genetic makeup, lifestyle factors, and coexisting conditions. This approach can improve the effectiveness of treatments and reduce the risk of adverse events. AI-powered tools can analyze data from wearable devices and remote monitoring systems, providing real-time insights into a patient's cardiac health. This can facilitate early intervention before a critical event and reduce the need for hospital visits, making care more accessible and cost-effective. AI can streamline administrative tasks such as scheduling, patient triage, and documentation, allowing cardiologists to focus more on patient care. It can also optimize workflow and diagnostic imaging by prioritizing cases based on urgency and complexity. AI systems can serve as clinical decision support tools, offering evidence-based treatment recommendations and alerting clinicians to potential issues like drug interactions or contraindications based on a comprehensive analysis of the patient's health record. AI can accelerate the pace of cardiovascular research by identifying potential therapeutic targets, analyzing clinical trial data, and simulating drug effects, which can lead to the discovery of new treatments and interventions. Simulation-based AI tools can provide interactive learning experiences for medical students and professionals, facilitating the acquisition of complex skills such as interventional techniques in a risk-free environment. While artificial intelligence and machine learning present vast opportunities for advancement in cardiology, it's essential to approach its integration with caution, ensuring data privacy, security, and ethical considerations are prioritized, and that these technologies complement, rather than replace, the clinician's expertise.
So is it actually true what our avatar is saying? And that's what I would like to discuss. So artificial intelligence and machine learning has been applied to genetics, face recognition, retina, voice, ECG, imaging, diagnostics, and prediction. And let's go through that and see what the data are showing us. Genetics, of course, is the first thing. Genetics are really complex. In the old days, when I was a medical student, they said that we have the genes and then we have a phenotype. But it's much more complex. The development from the genotype to the phenotype, first of all, we have lots of genes. We have 24,000 genes. 1,000 of them are based and in a meta-analysis on the development of coronary artery disease. And here are just a spectrum of them. So it's very difficult for a human brain to integrate such a message. And moreover, when we start with the genetic variation that you see here, we have modulation by lifestyle factors, smoking, blood pressure, and the like. And then, of course, we have post-transcriptional modification by microRNAs, long non-coding RNAs, phosphorylation, you name it, and eventually a phenotype. And therefore, we can have with the same gene a hypertrophic or a dilated cardiomyopathy. So this complexity of genes, epigenetic alterations, and environmental factors makes personalized medicine a real challenge. And a solution, of course, must be artificial intelligence. And here you see we can start with the variants, with the genome as such, and then add this to a large database, and eventually provide information for a particular physician as to what it means for a patient and its outcome. Secondly, when the patient enters your clinic, you first see his face. And face recognition is a real opportunity here in terms of the use of artificial intelligence. This is a paper I published when I was editor of the European Heart Journal from China. And of course, it's no accidental aspect that this comes from China. They're world champions in it. And you can see on the top what they look at. They look at the hair, the wrinkles you have here, the wrinkles on your front, the eye lobe and other aspects of your eye. Then below your eyes, the wrinkles here in the nose, your lips and the turgor of your lips, and the chin and below the chin. And altogether, they can then tell you what your risk for a coronary artery disease is. So you can see on the lower left, depending on how many of these features you integrate, you can come up with a more than 80% prediction of coronary artery disease using artificial intelligence. So next morning when you shave or you put your makeup on, watch yourself, and you can make already a pedestrian prediction that is much more sophisticated using artificial intelligence. Now, how good is it actually? In the validation cohort, you can see the algorithm had an area under the curve. One is perfect, but we never reach this in medicine. The algorithm has a AOC or C index of 0.757, while the Diamond Forrester score is significantly lower. This is in the validation cohort. In the test cohort, the difference was still there between 0.73 and a bit more than 6.6 to 3. So it's good. It's not perfect yet, and that needs certainly improvement. When they looked at different age groups, females and males, those with typical or atypical angina risk factors, and the extent eventually of coronary artery disease, you can see it was pretty good in those below and above 60 years of age. In females and males, it was comparable. In angina, whether typical or not, it was actually better with typical angina, as you would predict, with 784 compared to 714. For non-typical risk factors, a bit less good. And the extent of coronary disease was, of course, the best if there was three-vessel disease. So the next one is the retina. In medical school, we learned, and as fellows or SHOs were taught to look into the eyes, particularly in patients with hypertension and diabetes. But usually we don't do this because it's difficult and we don't have the experience because we don't regularly do it. But now there is help from artificial intelligence. And you can see on the left, there are different features of the retina. The retina thickness, then the vessels, the macula, and other features. And you can see the pictures that are obtained. And then there are two raters, and there is artificial intelligence. And artificial intelligence was as good as two experienced ophthalmologists. The next thing you can look at, or even if you run a phone clinic, as we often do since COVID, you can look at the voice of a patient. And of course, when you call your mother, you immediately hear whether she's in good mood or not, and whether she has an infection, an influenza, or anything like that. So intuitionally, it is very important to listen to the voice of a patient. And artificial intelligence can really analyze these waves that we see here that our throat produces. And here you can see the vowels that come in, then the speech frame analysis, the features that are then put into a matrix. And first of all, this is done for a sinus rhythm. And if you have a sinus rhythm in a patient, you can tell immediately if he no longer is in sinus rhythm. So you can actually detect atrial fibrillation, and this is good news for any arrhythmia clinic, using an artificial intelligence algorithm. More importantly, we also have congestion in our throat and in the vocal cords. So congestion in heart failure is the next thing to do. And this has been looked at by Elazar Edelman and co-workers from Boston, remote speech analysis in the evaluation of hospitalized patients with acute decompensated heart failure. And here is what they did. It was mainly done in Israel. There were patients with acute decompensated heart failure. They were hospitalized in a congested state. Then they had to record 5 sentences in their native language, and a voice analysis was performed. Then, of course, when they were decongested before they left the hospital, this was repeated to have a comparison between the congested and non-congested state. And you can see on the lower left that the mean of change from admission to discharge has been a little bit different with the different speech measures, and speech measures 3 and 4 were particularly changing before and after congestion, and therefore can be used after that when a patient calls you in, whether or not he again is congested. And the next thing we can look at when a patient comes into clinic is we perform an ECG. And an ECG is a very simple thing. And as cardiologists, we think we are the masters of the ECG. But the truth is we're not. We're pedestrian interpreters of ECGs. Because this is one study from the Mayo Clinic by Paul Friedman's group, an artificial intelligence-enabled ECG algorithm for the identification of patients with atrial fibrillation during sinus rhythm. And so you can see, first they looked at the patient with no atrial fibrillation rhythm recorded, and then patients with at least atrial fibrillation in the past. And this is really what Wittgenstein said. We learn this is a patient that had atrial fibrillation. This is a patient that didn't have it. This is a patient that had it. And they all are similar, but they're not identical. And this family characteristics is what artificial intelligence is able to pick up. Now, how good is it? Now, here we see the R area under the curve, and you can see this is really, really good. It's between 0.7 and 9. So this is almost perfect in the initial analysis and in the confirmation analysis. And the fantastic aspect of it is that it can detect those that had atrial fibrillation in the past. So when a patient tells you that he had a funny rhythm and you decide or not whether to prescribe a NOAC, you can use this algorithm. But of course, it has to travel from Rochester, Minnesota, also to the UK and Europe to finally be part of the everyday clinic. The other important development is GPs don't have an echo, but they may have an ECG. And so screening for cardiac contractile dysfunction using an AI-enabled electrocardiogram would be a fantastic tool to send the right patients to the cardiologist for an echo. And here's what they did. They took more than 600,000 ECGs, and then, of course, they wanted a transthoracic echo within 2 weeks, and they ended up with 163,892 patients that had these paired investigations. And eventually, they had 35,000 in an initial cohort, then about around 9,000 in the second one, and eventually, again, more than 50,000 to verify this. And what did they find? First of all, the area under the curve to detect left ventricular dysfunction was fantastic. You can see here the area under the curve is more than 0.9. close to perfection. There was a little bit of variation, as you can see on the right, but it was really impressive. And here is what happened. When they said initially the patient has been classified as a normal ejection fraction or classified in red, initially at low ejection fraction, you can see in the red curve that over 15 years, very long time, there was a 35% of these patients developed heart failure. In those that were classified as normal ejection fraction, also 10% developed heart failure. Possibly some of them have PEF. Well, we don't know this yet, but the separation is truly interesting. Finally, a good tool is artificial intelligence-enabled assessment of the heart rate for corrected QT interval using a mobile ECG device. This can be really very useful in clinical practice. And here again, the computer was extremely good with an AOC between 0.8 and 9. All right, so the next thing, of course, is imaging. And artificial intelligence is very good to look at structures and pictures, be it in cardiology and pathology, or even in dermatology and any radiology aspect of our organs. And so let's first look at echocardiography. So this is an automated echocardiographic quantification of left ventricular ejection fraction without volume measurements using a machine learning algorithm mimicking a human expert. Mimicking a human expert. And here you can see the machine learning on the left and the clinical readers on the right. On the top, this is the precision. And on the lower end, this is an Altman plot that shows the variation. And you can see that truly the machine learning was as good as a human expert echocardiographer in looking at the volumes and left ventricular ejection fraction eventually. The next one is mitral inflow Doppler analysis. This comes from the Mayo Clinic again. It is not reviewed yet, but it was accessible on this platform for non-submitted or papers in submission. And you can see here the flow chart of fully automated mitral inflow Doppler analysis. And then on the right-hand side, the automated mitral inflow analysis compared to operators. And you can see that the precision comparing automatic and operator-derived mitral inflow pictures or patterns is quite remarkable. And also the Altman plots are pretty good. They can be improved. It's not perfect yet, but I would argue that even two operators wouldn't be perfect either. Then, of course, computed tomography is the next thing that we have to look at. Here is a state-of-the-art review article by Charalambos Antoniadis from Oxford and his team that developed a new way at looking at CT coronary angiograms. And what they developed is you see what you can't see. As the avatar said, AI is better in looking at these pictures than any radiologist. And here you can see a plaque in a coronary artery that is inflamed. And this plaque will develop cytokines, and on top, it will digest the lipids, that perivascular lipids around the coronary artery. And this is seen in the coronary CT angiogram as the so-called fat attenuation index. It is black. And this differences in blackness is what the algorithm sees by analyzing CT angiograms. And you can see here on the top right, a culprit lesion in a patient with an acute myocardial infarction. The black spots are, of course, the digested fat around the coronary arteries because of an inflamed plaque that was the culprit of the acute myocardial infarction. And on the lower end, you see a non-treated plaque that is a stable coronary disease where there are much less black spots because there's less inflammation. So it's not the plaque that kills you, it's the inflammation of the plaque that kills you. And this is really what's shown here. First of all, they looked at the non-invasive detection of corneal inflammation, and they validated this by biopsies from arteries obtained at bypass surgery. And you can see that the area under the curve in model 1 and 2 is really quite impressive. But more than that, we want to know whether these inflammatory plaques that maybe are not even obstructive or cause angina, whether they're important for outcomes. So they looked at these segments of these coronary arteries that you see on the right, on the left, I'm sorry. And then they looked at the outcome of patients over a large number of months. And you can see on the top, the derivation chord for all-cause mortality in panel A and panel B for cardiac mortality. In C and D, it's the validation chord again for mortality and cardiac mortality. And you see in red and blue above and below the median of a fat attenuation index, and you can see very, very impressive separation in the B panels and D between those that had inflammation and those who had not in the CT scan. So this is a prediction that is really beyond any of our risk factors we currently use. Then, of course, diagnostics. So let's see how good actually the avatar is in diagnosis cardiac symptoms and comes up with the right guess on what it actually is. So we asked the avatar what it is, and we submitted a case. Thanks to Rakesh Sharma.
40-year-old male patient presented with dyspnea and was found to have third-degree atrioventricular block AV block 3. Coronary angiography revealed no abnormalities in the coronary arteries, and pulmonary artery CT was negative. Echocardiography and cardiac MRI demonstrated preserved systolic function in both ventricles. Following the clinical findings, a cardiac resynchronization therapy defibrillator (CRTD) was implanted. Subsequent FDG PET CT imaging revealed focal tracer uptake in the cardiac septum, indicative of a potential non-ischemic or inflammatory cardiomyopathy. Based on the presented case details, the most probable diagnosis for this patient could be cardiac sarcoidosis. This is suggested by the combination of third-degree atrioventricular block AV block 3, preserved left and right ventricular systolic function, normal coronary arteries, and especially the focal accumulation of the tracer in the septum of the heart on FDG PET CT, which is indicative of inflammatory activity. Cardiac sarcoidosis is a multi-system granulomatous disorder that can affect the heart, leading to various cardiac manifestations, including conduction abnormalities like AV block, arrhythmias.
So the next thing, so you could see that really the avatar is actually very well educated. It can do differential diagnosis. It made the right diagnosis as confirmed by Rakesh and the MDT at the Brompton for sarcoid heart disease. But it goes beyond that. There is a large language model that developed by Google. And here is an article by Nature just the last month. Google AI has better bedside manners than human doctors. Wow, what is this? Now, towards conversational diagnostics, this is a Google research paper by Tao Tu and co-workers that actually simulated with actors, as we have it now in the final exam, a talk between a doctor and the patient to determine actually the diagnosis or a first suspicion of a diagnosis. So they compared Articulate Medical Intelligence Explorer with primary care physicians in a randomized double-blind crossover study. And they studied 149 case scenarios from clinical providers and 20 primary care physicians were involved as well. So what did they find? Well, first of all, they did step one, looked at the data and so forth, and basically did an online test-based consultation, then post questionnaires, and eventually this was evaluated by specialized physicians. And here is the outcome. You can see the Articulate Medical Intelligence Explorer, a large language model based on an AI system optimized for diagnostic purposes. And you can see the accuracy here on different scenarios. In blue are the primary care physicians, and in red, this is the artificial intelligence. And you can see that throughout these different scenarios, the artificial intelligent algorithm beats primary care physicians on all accounts. Now, obviously, this is a relatively small study with 20 primary care physicians. And secondly, the patients were played by actors, and therefore we have to take this with caution. But it really shows what Simon Davis, my colleague and friend, asked this morning: can we use it in our clinic? Well, we could. It could prepare the patient so that we have already some probabilities of what the patient may go to, or where he fits into our diagnostic categorization. And so this is quite remarkable. Then furthermore, machine learning was used for the diagnosis of myocardial infarction, using not a single cardiac troponin level, but rather a continuum, and taking into account the time from symptom onset to arrival at the A&E unit, and furthermore also comorbidities. So it's much more sophisticated than what we have now in our guidelines. And you can see on the left is the sensitivity and specificity. There's an area under the curve close to 0.9. And the precision on the right is also quite remarkable. And therefore, this code ACS score that has been used here using artificial intelligence could be very useful in the emergency units. Here is the AOC of 0.953, which is really quite remarkable. Furthermore, with this algorithm, they could predict over 360 of days, one year essentially. They could predict the cardiac death and all-cause mortality. Cardiac death was much better than overall mortality, as you would imagine, for those that had a high risk, middle risk, or low risk of acute myocardial infarction. Then, of course, we are at prediction, because in many diseases, we want to predict how dangerous the disease is, because it will affect our management quite substantially. And so with Florian Wenzel in our team, we looked at the management of non-STEMI ACS in the UK and Switzerland over 15 years. And you can see on the left, the invasive management, on the right, the discharge medication. The invasive management was really the opener. You can see that in the UK, but also in Switzerland, females get much less angiograms when they present with a suspicion of a non-STEMI ACS. Moreover, PCI is much less performed, only in half of the patients. Even in Switzerland, it is not perfect at all. And eventually, when patients leave the hospital, they get less statins when they are female compared to males. So we did actually in 450,000 patients with non-STEMI ACS, a sex-specific evaluation and redevelopment of the GRACE score, which is a risk score in hospital in non-ST segment elevation acute coronary syndromes, recommended in all guidelines in the US and in Europe. And we compared, as I said earlier, any algorithm has to travel well from the UK to the continent. And so we used the Swiss cohort to make sure we obtain a proper algorithm. First of all, you can see up there in the ESC guidelines, the recommendations for the non-STEMI ACS patients for the GRACE score. And on the lower panel, you can see sex differences in feature of importance. And of course, males and females do differ, as you would expect, and as we know very well. And therefore, there is a poor calibration of this very algorithm. So with machine learning, we used, first of all, a first cohort of around 12,000 patients, then the MINAP registry with more than 400,000 patients using machine learning, and then went to Switzerland in 20,000 patients to confirm the algorithm, providing an app that is now online accessible for everybody to assess risk in patients, no matter whether they're female or males. And here is the performance of the grade 3 score developed by machine learning. It accounts for sex differences. It has excellent discrimination and good calibration, as you can see in the lower panels. That is really a straight line. Of course, here, this is now available on the net, and you can add these information quickly and get an appropriate risk score to determine or not whether an interventional measure would be appropriate in a patient with non-STEMI of both sexes. Then, of course, my former fellow Fabrizio D'Ascenzo, now working in Torino, looked at what can we predict in the long run. And this is machine learning-based prediction of adverse events following an acute coronary syndrome. The PRAISE study published in The Lancet some years ago. And you can see here that with all-cause deaths, recurrent acute myocardial infarction and major bleeding were very well predicted. All-cause deaths with an area under the curve in the range of 0.82 to 0.92. Then recurrent MI with a bit less good, 7.4 and 8.1. So all these data show how good AI is and that it is not perfect yet. So we have to still work on it to make it better because, of course, ideally, we would like to have 0.9 and above in most instances that we use in clinical practice. Now, you can see also when you look at the different deciles of predicted risk that the algorithm comparing observed in red and predicted in blue is not as good in the top decile of predicted risk for all-cause deaths, recurrent acute MI, or even major bleeding. So the risk observed is an event probability based on the PRAISE score here that is good, but not perfect yet. Then, of course, I would like to end with a small study that has been done by Michael Gatsoulis and Paul Diller at the Adult Congenital Heart Disease Unit at the Royal Brompton Hospital. Machine learning algorithm estimating prognosis and guiding therapy in adult congenital heart disease. This is just one picture predicting the use of ACE inhibitors or RRB therapy or prediction of anticoagulation therapy. And you can see there's actually a very, very good prediction. And this is, of course, comparison to an MDT that took place at the Royal Brompton Hospital. So let me finish with the question whether the algorithm is also good in teaching. And here you can see another algorithm or avatar.
TAVR is a procedure that has revolutionized the management of patients with severe aortic stenosis. Artificial intelligence has the potential to greatly aid in various stages of the TAVI procedure.
So if you ask the avatar to give a lecture on TAVI, on aortic stenosis, it is amazing how good it is. So I would like to finish here. The future of cardiology is machine learning. We can use genetic information. We can look at epigenetics. We can have risk scores developed by a huge number of parameters obtained clinically, biochemically, with ECG, imaging, and the like, but also in the intensive care, in the emergency unit, and eventually also when we see patients in our clinic. And in the clinic, it will help us for the first impression of a patient with face recognition, with all the different parameters we obtain, and even in the future can start the discussion with the patient to provide us with an initial analysis of the potential diagnosis with probabilities to aid us to be quicker, more efficient, and eventually, hopefully, we'll have more time for our patients. So artificial intelligence really in cardiology is not a threat. The avatar is a good friend that helps us to even become better in medicine. And with that, I would like to thank you for your attention.
Tom, thank you very much for a fantastic review of the of this topic and the breadth of things that you've covered. And clearly, looking at this, the future is here now in terms of what the AI and machine learning can do. And I think, there's some real fundamental questions about how we're going to use it for the benefit of our patients, for the benefit of making healthcare more affordable. All societies struggle with how do you make healthcare more affordable and to cover the entire population. And clearly this is one of the tools that's going to be able to do that. If anybody wants to add a question, either put it in the chat, or if you raise your hand in the normal kind of way, I can hopefully we can see that and take questions. I mean, one of the things, Tom, is this could change the whole way that we train doctors and what it means, or what skill set you need to actually be a doctor. And traditionally, to even get into an entry for being a doctor, you had to retain a lot of information and be able to regurgitate it in exams. What's your sense of how we might change and how this may impact on that?
Well, it will certainly change. When I came back from the US, I was an echo person at that time. And my boss at the time in Basel, he said, I don't need an echo, I have a stethoscope. And I did a lot of patients in his clinic when I was using the echo at the time when I was responsible for it. And I discovered that, the stethoscope is a good tool, but it's far from being perfect to detect valvular heart disease or any other issues. And I think the same will apply now with ECG. In the old days, we spent lots of time to learn how to interpret the ECG, and our next generation will get an output from AI. And this will, of course, reduce the competence of reading ECGs without it. But they will have new competencies, I would argue, and they will learn how to use the information that artificial intelligence provides. And they have to learn to critically interpret it, because the algorithms, as I indicated early on, if they are not traveling well to another country, then, of course, we cannot use them clinically. They have to be solid, and they have to work in the UK and Sweden or Switzerland or any other country and have to be evaluated continuously, because the profile, the phenotype of our patients also changes. As an example, when patients now, all of patients have a statin, let's say, the outcome of infarction is different than in the old days where people received the statin only after the event. So we have to critically evaluate these algorithms and learn how to do this properly.
Thank you. I can see a question from Professor Panos Vardas.
Great, thank you very much. Thomas, congratulations. As usually, very nice review around the very recent developments. No doubt, there is a plethora of issues to comment and discuss around these earth-shattering changes. Just only two comments. One, I recognize one of your papers focused on the polygenic risk scores, PRS, okay? Very recently, in Brussels, we had a great discussion around and a great debate around these scores. And we have to recognize that around these scores, there are many practical, philosophical, regulatory issues, huge. Imagine if at your age of 15, you know that you have 10 or 20 times more possibility to develop cancer or stroke or everything, or anything. But just I would like to comment something else. I would like to remind to the audience here, as an AI freak, that recently I published in your journal, at least until recently, the European Heart Journal, an article under the title Medicine at the Dawn of the Metaclinical Era, very much aligned with your enthusiasm. And just because I feel, let's say, a little bit enthusiastic here, I would like to read what I wrote here, what we are calling metaclinical medicine as a term to define medical developments. In other words, we coined a new term, metaclinical medicine. And here we mean that from one point and later, the AI developments will be such huge soon, and then the decisive role of the physician will be diminished. At the moment, the physician, although is supported by advanced technologies, MRI, endoscopy, etc., still has the decisive role. But if the decisive role of the physician in 20 years from now, 50 years from now, is not such, if the ECG indicates 20 AF episodes in the past using the superhuman capabilities of AI, excuse me, but the decisive role of the physician is going to be go down. That's why at the moment I'm writing a paper about the non-human physicians, an unavoidable fate of medicine. What's your opinion?
Well, Carlos, thank you very much for this comment. I think the difference at the moment, at least, is that artificial intelligence has no ethical sense, has no empathy, and it has no cultural background. Whether or not this can also be included into an algorithm, I don't know. I wouldn't be surprised of. But I would also like to comment quickly on the genetics. I think genetics and probabilities, let's say you have a genetic probability of developing cancer of the belly, then why don't you do a coloscopy every 5 years? If you have a gene for diabetes, why don't you make sure that you don't gain weight? If you have a genetic propensity or a disposition for stroke, why don't you make sure that you have very low blood pressure throughout life? So I think the genes can also tell us how to organize our health.
Yeah, but sorry, but I agree with you. But imagine that using the polygenic risk scores, the use of the statins could be increased by 100%, correct? We have to start taking statins. And may I ask you another question? What is going to be the role of a physician if during a colonoscopy the artificial intelligence indicates a 10 times more possibility to develop cancer, while the physician is very much satisfied about the findings? Who is the decisive now? Who has the upper hand?
It depends how good the algorithm is. If it's really very well established in several, it's like a clinical trial. You need at least 2 clinical trials to have a 1A recommendation. An algorithm has to have at least 2 or 3 verification cohorts to be valid.
Yeah. In my opinion, metaclinical medicine is something unavoidable coming very soon.
Yeah, I think this is going to change. I think, as you say, change the way that we practice medicine, how patients interact with the clinical staff in ways that we can only imagine and work through. I've got some more hands up and questions in the chat. So Rakesh, do you want to ask your question? Then I'll come to questions in the chat.
Thanks so much, Richard. And thank you, Tom, for a fantastic presentation. I think we should certainly invite your avatar to our cardiac sarcoidosis MTT meetings. It's just a comment, really. So I think as doctors, we should certainly embrace this technology, because I think some of the fears that we've had is that AI will take over our jobs. I don't think that's the case. I think it is a tool to try and help us do our job better. And one of the concerns we have in our own group is that patients with rare diseases like cardiovascular, very often the condition is diagnosed very late when they present with a kind of present with a catastrophic arrhythmia. So there must be many patients out there with the condition where the diagnosis has not been made. So I think if we have an algorithm which is well validated, which we can roll out to the rest of the clinicians in UK and beyond, we'll pick up much more disease and we'll get much more work. So, very good presentation, very excited by it.
Well, thank you, Rocket, actually for providing the case, and I'm delighted to work with you on sarcoid heart disease. I would also mention that my plan would be that in the ESC, we would have guidelines that are actually algorithms where you can ask questions. What is the recommendation of the ESC guideline on acute coronary syndrome? And this patient that is 85 years old has a bleeding risk and so on. What should I do? And rather than reading 60 pages, you get an answer like this.
I'm sure that is coming. So there's some questions and comments in the chat, Tom, which I'll go through. Cecilia is imagining a world where the patient turns up to the emergency department already with their diagnosis made by the computer and their phone on the way into the ED. And how do you think we should prepare for a world where that happens?
Well, thank you, Cecilia. I mean, this is already a reality. If I have a patient with aortic stenosis, they already were in the net to check and they say, I want a TAVI rather than an operation because I read about it. So this is already reality with the internet. It just will become much more sophisticated and maybe also much more useful for the doctor than some of the information that currently is in the net.
Thanks. And then Adolfo, another question on the sort of future of doctors, really, and the future of medicine around how AI is going to change medical school. Can we use this? Is this going to make, probably many people on the call know that there is a challenge in the morale of junior doctors at the moment, particularly in the UK, but I think also probably across other parts of Europe. And do you think AI is going to, and this technology is going to attract more young people into being doctors of the future, or people can be put off thinking that the future for medicine is, as Vardas described, one where diminishing value?
I think that the iPhone generation really embraces this technology. We are maybe not as IT literate than the youngsters, and I often have also to ask my kids how to figure out a feature in my iPhone. They like these things, they grow up with it, and so I don't see a problem. But of course, there are challenges, and there's a backside of AI. If we think of, for instance, of exams, the examinations have to be done in secluded rooms, really, because if you can use artificial intelligence during an exam, then of course everybody has a top rating eventually. So this is, for schools, it's even worse. I mean, there are downsides of AI that I don't want to hide.
Yeah, and maybe somebody will ask, or will come to, what do you think the risks of these of the spread of AI? With a question and comment and question from Kavitha, loves to talk. Given the multitude, the plethora of AI algorithms, the everyday translation, clinical translation remains low. So what do you think are the main challenges, barriers in really integrating and implementing these agents and algorithms? I don't know whether we call algorithms agents or avatars agents into clinical practice. And how do you think patients react to talking to an avatar or talking to something where they think it's not the doctor that's driving the decision making, it's the computer?
Well, these are very, very good questions. First of all, we recently had a meeting with the European agencies, and they consider an algorithm a device. So it will be evaluated like a device, like a heart valve or a pacemaker or something like that. And of course, the evaluation and registration of these algorithms is a real challenge. We have to assure that these algorithms, and I showed you some of the examples where we have huge numbers. If an algorithm is derived from 400, 500,000 patients, it has a completely different quality than if it is derived from 10,000, let's say. So we have to develop criteria for a quality of an algorithm. And I'm sure that the ESC, and I will certainly do this when I'm in charge, will have to develop criteria that are helpful for the doctors to judge the quality and the usefulness of algorithms that are available. And we will certainly work closely with the European agency, and I would be actually also interested what the UK agencies that are separate now would think about it. And I think these are very, very important aspects. The FDA also has their saying here, but we need criteria, and doctors have to learn that as we are evaluating trials today, trials is the p-value significant, is the effect size relevant, and so forth. We learned that. We have to learn the same for the algorithms.
Thanks. Time for we've got two great questions that I want to try and get in. One from Michael Gatsoulis around any data on AI and empathy, and whether patients have been engaged on this advance and the opportunity for patient education empowerment. Any data or studies that you know on that?
Well, if you ask the avatar, she says that she doesn't have empathy, and that's the main difference between a human and the algorithm currently. Whether we can program an algorithm to have empathy like a human brain, I wouldn't deny this, but I haven't seen any data on that so far. But this is, of course, an important role currently of the doctor to use data with judgment, with empathy for the patient. Being the advocate of the patient remains important, and also judging whether or not the algorithm that has been used is available, is a precise and reproducible for this current situation of a patient.
And certainly, I think scope for lots more development on that. And final question, I know we're slightly over time, but this is a great question around the risk of AI overdiagnosing and generating overtreatment, and where you draw the line around future risk, because I presume that the AI is going to get so good it might predict you're going to get your cancer before you actually get it, or you're going to have your heart attack before, and then. So I think it's a great question. Any thoughts around that?
Well, of course, the algorithm can also fantasize. That has been shown, and depending on how good it is, he's more precise, or he just fills in stuff if he doesn't know what to say. That's a real danger. But this is also, a children's disease of the technology. But I think, basically, the role of the doctor is still there to judge whether for this particular patient, what is recommended by strict data, strict guidelines, is really appropriate for this patient. Because the guidelines that the algorithm derives its recommendations from are really not the Moses' 10 commandments. These are recommendations, and we can deviate from it if we feel it is necessary and appropriate for a given patient.
Yeah, no, well said. Thank you. I mean, absolutely fascinating topic, and the future is going to dramatically change, and I think again, it's beholden on all of us to be engaged and to use these tools and work out how we can use them for the benefits of patients, society at large, avoid the pitfalls. But it certainly looks like it's going to be quite fun in terms of looking at what can be done. I mean, the ECG data from the old boring 12-lead, sorry if there's any EP doctors, but the standard 12-lead ECG that we all struggle to learn as medical students, and then you look at cursory glance that it can reveal all this information is quite extraordinary. So listen, Tom, thank you very much. Avatar Emily, thank you very much. She may like to be thanked, even if she's an avatar and has no feelings, but we'll thank her anyway. Thank you, the audience.
Thank you, Richard, for
your
sharing.
questions and engagement. And we'll see you next time for the next of these talks. Thank you all.